Welcome, everyone, and thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our speakers today, who I'll introduce to you shortly. Our webinar today is titled Empowering Pharmacists to Support Tobacco Cessation in the Western Pacific Region. It's a co-organised event by FIP in collaboration with the Western Pacific Pharmaceutical Forum. So let me start by introducing myself. My name's John Jackson, and I am the president of the Western Pacific Pharmaceutical Forum. In the Western Pacific region, 22.5% of people aged over 15 years are tobacco users. Given the global and regional prevalence and burden of tobacco use, particularly as a risk factor for non-communicable diseases, it's important that the role of the pharmacist in tobacco use prevention and cessation is expanded and consolidated. And today, you will learn about the burden of tobacco use in the Western Pacific region and the role that pharmacists can play in tobacco cessation. The event will include country examples of pharmacist services and a presentation of FIP resources to advance tobacco cessation through pharmacists. The webinar will run for 1.5 hours, and first there are a few announcements that I'd like to share with you, as shown on this slide. Please note the event will be recorded and live streamed on FIP YouTube, and the recording will be available at events.fip.org. To all of those listening, please feel free to send your questions through the Q&A box, and provided we have time, we'll try to get to those questions at the end. You're welcome to provide feedback to webinars@fip.org. And of course, I would heartily like to take this opportunity to promote the benefits of membership of FIP, including events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. So now let me come to the speakers, the panel of fabulous speakers, and I want to sincerely thank each of them for taking their time to prepare their presentations. In the earlier announcements, it stated that we were going to hear from Mina Kashiwabara from the World Health Organization Regional Office in the Western Pacific on the burden of tobacco use and the implementation of tobacco cessation policies across the WHO Western Pacific region. Due to a lack of clearance for her attendance, Mina is not able to attend. I will provide some of this regional information shortly. After my presentation, Peter Guthrie from the Pharmaceutical Society of Australia will speak on tobacco cessation services by pharmacists in Australia. Andre Hiwen-Yu, a certified tobacco cessation pharmacist from Taiwan, will speak on tobacco cessation services provided by Taiwanese pharmacists. Professor Mohammed Hanaki Nik Mohammed will speak on tobacco cessation services by pharmacists in Malaysia. And Atsushi Toyomi will speak on tobacco cessation services by pharmacists in Japan. Those 4 speakers will give you a very broad understanding of what pharmacists can achieve in this region. To conclude, Dr. Ines Nunes da Cunha will tell you about FIP resources to empower pharmacists to support tobacco cessation. And hopefully, with some time, we'll have some Q&A before we wrap up. On this slide, you'll see the learning objectives of this webinar. You'll learn about the burden of tobacco dependence in the region, the importance of leveraging pharmacists for tobacco cessation in the region, examples of tobacco cessation services provided by pharmacists in the region, and FIP resources to support pharmacists in tobacco cessation. So to start our proceedings, I want to provide a picture of the burden of tobacco use across the region. To do this, I'm grateful to the slides that Nina from WHO was going to use. They've been adapted for my presentation. On the next slide, you can see that tobacco kills. More than 3 million deaths in the Western Pacific region every year. There are two lines on this chart that you see. The blue line is the global record of the number of tobacco users over this period from about 2000 projected out to 2030. And you can see there's a downward trend in that line. The lower or gold line are the number of tobacco users 15 years older in the Western Pacific region. And it's somewhat disappointing, of course, that that line is not falling at the same rate as the global line. We'll see what we can do about that tonight. On the next slide, what we find is that there's a direct link between tobacco use and early mortality. Tobacco use is, of course, a modifiable risk factor, along with things like unhealthy diets or lack of physical activity and harmful use of alcohol. And all of those risk factors can cause intermediate clinical conditions, increased blood pressure, abnormal blood lipids, raised blood sugar, obesity, which then lead us to the disease endpoints, such as hypertension, hyperlipidemia, diabetes, obesity, and cancer. The next slide, we see that, thank you, there's one way to get politicians' attention about health issues, and that's to express it in terms of an economic cost. This here shows 4 countries, the Lao Democratic Republic, Cambodia, Fiji, and Samoa, and the actual cost to those countries of tobacco use. It's expressed in the impact on the gross domestic product in those countries, and you can see it ranges from about 2.5% to 3%. That's a very, very significant cost to these countries of the use of tobacco. So, moving on to the next. What happens when politicians get concerned about something like this? The WHO got support from countries back in 2003 to develop a framework convention on tobacco control, and this came into effect in 2005. And by now, 183 countries have signed on to this tobacco control convention. They cover 90% of the world population, and these countries have committed to strategies which will reduce the demand and decrease the supply of tobacco. The next slide just shows the actual article, Article 14 of that convention, and it's a legally binding obligation on those countries to act to try to reduce tobacco use. The next slide, which is quite complicated, has a lot of examples of how tobacco cessation and reduction can occur. There are measures that could be taken to reduce the supply of tobacco products, stop illicit trade, get growers to grow alternative products, stop sale to minors. So a lot of activities that can be taken to reduce the demand for tobacco products, increasing taxes, education and awareness, removing advertising, and then there are a range of other key measures. But on the next slide, I want to take you to some very, very specific measures that have been shown to be effective in reducing demand for tobacco. This is also work of the WHO Framework Convention on Tobacco Control. And there's an anagram, Empower, which arises from monitoring tobacco use and prevention policies, protecting people from tobacco smoke, offering to help people to quit tobacco use, warning people about the dangers of tobacco, enforcing bans on tobacco advertising, and raising taxes on tobacco. Those 6 actions are evidence-based interventions to reduce tobacco use. The next slide, we see some of the detail of how this is playing out in the Western Pacific region. Across the bottom, the darker bars at the bottom of the bar graph show those countries ranging between 4 and 6, depending upon the year, those countries that have established national quit lines or provide nicotine replacement therapy with some kind of cost covering. Above the dark blue, in the middle of the bars, are the medium blue colours, and between 10 and 18 countries that mightn't have quit lines, but they've got nicotine replacement therapy with some kind of funding for the service. And further up each of those bars, you can see there are countries that have just got nicotine replacement therapy. It is very pleasing to see the increase in number of countries that are providing some kind of financial support for nicotine replacement therapy. So moving on to the next, we see that there are examples here of some of those quit lines that were mentioned in the previous slide. So different types of quit lines that exist across our region, a 24-hour quit line in New Zealand, quit lines that people can call where there is no charge, or others where there are charges. And I'm sure we'll hear more about these later. Moving on to wrap this section up before I introduce the first of our speakers. There is one day every year, the 31st of May, which is World No Tobacco Day. And what that should show you at the top of the slide is that 31st of May 2025, not 2005, the theme of World No Tobacco Day next year is the role of health professionals against tobacco. And of course, health professionals like pharmacists have a professional obligation to assist people avoid harmful health things like tobacco use. We can play role models, we can be educators, we can apply our clinical expertise, we can provide opinion and help build alliances. So in the next slide, let's look very specifically at how pharmacists can do this. What this busy slide shows you is that interventions by pharmacists as short as 3 minutes counselling somebody on how to quit can help them. As the number of, or as the duration of counselling increases, the percentage of people who quit increases. That's the evidence in the table on the left as you go from studies that showed either 3 minutes, 3 to 10 minutes, or more than 10 minutes of counselling for people to quit. The percentage of people who quit increased from 13%, 16%, up to 22%. So let's move on from there, and we're going to actually hear in a second from some of our colleagues from around the region as to how you can assist people to quit tobacco use. When you receive these slides, when you go on the FIP website to access these slides, you'll be able to access these links to be able to read some of the WHO material in this area. So at this stage, what I'd like to do is start by introducing the first of our speakers, and it is Mr. Peter Guthrie from Australia. Peter holds the position of Senior Pharmacist for Strategic Policy at the Pharmaceutical Society of Australia, where he supports policy development, advocacy activities, regulatory submissions, and practice development. Peter is also an executive committee member of FIP's Social and Administrative Pharmacy section. He's got over 16 years of experience in pharmacy policy, regulation, advocacy, quality management, and community pharmacy practice, where he continues to work on a regular basis. Peter, I'd like to invite you to give your presentation. Thank you.
Well, thank you very much, John, and a really warm welcome to everybody who is watching live tonight or might be watching on replay. A particular welcome to my colleagues across Australia. I can see some on the line. If there are any Aboriginal and Torres Strait Islander people watching tonight, I do wish to acknowledge that we come from Aboriginal land and wish to acknowledge elders past, present and emerging. It's a really exciting topic to speak on, tobacco cessation. I practice in a country which has been a world leader in progressing a number of aspects of smoking cessation. So I'm looking forward to sharing aspects of that have worked really well. Some of those are around the public health policies that John has just outlined, and others relate to the one-on-one patient relationships that health workers have with individuals who are seeking to stop smoking. So I'll first look at the patterns of tobacco use in Australia, and we'll start first with a graph that looks over a large number of years, I guess the rise of smoking in Australia, then followed by the strategies that have been helpful in reducing the percentage of the population who use tobacco. Now the graph scale on this one is interesting, and it relates to the weight of tobacco per capita in the population. So it may not be a perfect indicator of the percentage of the population which is smoking. But what we can see from this image is that from a peak of in the sort of around 1959, 1960, as the harms of tobacco use became more evident and the evidence base emerged from that, Australia was quite proactive in seeking to control, regulate, and to reduce the population's use of tobacco, initially through measures such as the banning of cigarette ads on television in the 1970s, and through the 1980s, one of the world-leading quit smoking campaigns. This also saw a complete ban on tobacco ads in print media in sort of the late 1980s, and then with progressive reduction in advertising through sport and other media forms. More recently, this graph and then the graph on the subsequent slide shows that measures such as taxation and the regulation of tobacco packaging has been quite instrumental in reducing smoking rates in Australia. What we can see here are a couple of things that were world leading. One of those was the progression of smoke-free dining in hospitality venues. And the second of those, and probably the most famous around the world, was Australia was the first country to remove all logos and colours from cigarette packaging. We're one of the world leaders with images on our packs, and I'll show a few more of those in a sec. The other big factor that has reduced tobacco use in Australia is some fairly substantial taxation increases on the cost of a packet of cigarettes and other forms of tobacco, and those have made tobacco use increasingly unaffordable for a large number of Australians. The next slide shows that things aren't all great, though. We have seen since 2018 a steady and probably, if we were to graph further data points on the end of this slide, a fairly rapidly increasing use of vaping in Australia. And this is not unique to Australia. Australia's response to vaping is somewhat unique, and I'll touch on that later in the presentation. But Australia has decided to go down a regulation model of being a therapeutic approach as opposed to a tobacco control use, and we'll talk a bit more about that a little bit later. So we have seen a surge in use of nicotine vaping within minors and adolescents, and we have also seen increasing use in populations that have previously quit nicotine smoking. One of the concerning aspects that we've seen in our tobacco smoking rates is that for the first time in several decades, we've seen an increase in the rate of minors who are trying tobacco for the first time, and that is something of significant concern to our health authorities. I touched briefly on the public success stories, and I'll quickly run over those now to demonstrate what I was talking about. The first of those was our world-leading tobacco packaging regulation. We have a couple of images of those coming up, where not just were there warnings on the pack, and these warnings get recycled. There's several batches of these warnings, and these are legally mandated warnings to be on tobacco packaging. But the colour of those packs is a rather unpleasant and unappealing sort of browny green colour. They did a lot of research to find what was the most unappealing colour in terms of a consumer wanting to access a product. And the use of any logos or branding has been really brought back to plain text, as you can see in the examples where it says brand and variant there. Some of our cigarette advertising campaigns on television were also very effective. The next slide shows that the second point, we had a campaign called Every Cigarette is Doing You Damage, and I certainly recognise those growing up from my childhood. We then had a really fantastic follow-up campaign that said every cigarette you do not smoke is doing you good, and it closed with this image of a beaker filled with tar from a person's lungs. This has evolved, as we see on the next slide, into something that is more nuanced in result to the change in viewing habits of the population and how people engage with media. So we now see much of this advertising occurring through social media, and this is an example of a recent campaign by our Medical Research Council relating to e-cigarettes not being without harm. Our government has recently launched quite a few social media campaigns, including the use of social media influencers with regard to vaping and there as well. So what does this mean for smoking cessation therapies in Australia? Our next slides sort of look at what are the options that we have available to us in our population. In addition to talking therapies, and John touched on the fact that Australia and many other countries in the Pacific region do have telephone support services where you have a phone counsellor that can talk to you about your desire to stop smoking and how you might go through that quit attempt. We also have medicines that can assist with this, as John touched on. In Australia, both varenicline and bupropion are available, although we have had stock shortages at different times of both of those products. And also on prescription only in Australia, any nicotine containing vape is lawfully only allowed to be supplied on prescription through a community pharmacy at this point in time. However, that said, there is substantial retail model for vapes that, while not declaring nicotine, do contain nicotine. So the vast majority of nicotine-containing vapes accessed in Australia are not at this time being accessed through a health setting. We also have non-prescription medicines available, and that includes nicotine replacement therapy. In Australia, we have a wide range of nicotine replacement therapies available. In addition to the patches and the gum, we have the lozenges, the inhalers, and the mouth spray. These are all available in any retail setting that chooses to sell them. However, if a person would like to access a government subsidised nicotine patch through Australia's Pharmaceutical Benefit Scheme, that reduces the cost to around $30 Australian per month, or if you're a pensioner, $7.70 Australian per month. That can only be accessed through a community pharmacy on the presentation of an eligible prescription from a doctor. Varenicline and bupropion are also available on prescription in Australia. Through government subsidy. All of these products have conditions regarding how doctors are permitted and not permitted to prescribe within the subsidised system. So what does the role of pharmacists look like? And we have on the next slide a really great guidance document. I work for the organisation that Pharmaceutical Society of Australia that produced this guideline to support pharmacists help people quit smoking. Within this document, it states a very clear purpose that pharmacists should have a system in place to identify patients who smoke and to document their tobacco use. Everyone who smokes should be given brief advice on smoking cessation at a minimum, and John touched on that earlier. The document also, as the next slide shows, has a really great flow chart on what the provision of a pharmacist-led smoking cessation support service looks like, whether that is to provide brief advice and direct bill towards another prescriber for prescription-only medicines, to offer nicotine replacement therapy, or provide other follow-up, and it has a hierarchy there you can see. The Pharmaceutical Society also produces e-learning support for our members. We have a treatment guideline which sits within our National Pharmacopoeia, which is known as the Australian Pharmaceutical Handbook, and we provide support to our members through a telephone line as well. In terms of how pharmacies provide the service, the next slide gives a couple of examples. The first of these is that the typical way most people will engage with smoking cessation is to walk into a pharmacy and request access to nicotine replacement therapy, for example. And this is an ad hoc, informal conversation where a short intervention of a couple of minutes is possible. That service is generally not remunerated. The second opportunity, which the next slide has an example of, is a number of the pharmacies in the country offer formal sit-down counselling services where you'll have a chat with the pharmacist regarding your healthcare, with your smoking needs, and there'll be a plan developed onto how you will respond. This is a screenshot of one of the pharmacy's websites that I took when I put this presentation together. Again, the appetite to pay is not always high, but it does help consumers access a number of the medicines that the pharmacy does have available for purchase. The next slide is another quite interesting model where in one of our tertiary hospitals here in Melbourne, they've really ingrained as part of their culture of going smoke-free, a pharmacist-led smoking cessation service in the hospital. Their entire hospital site, including outdoor areas, is smoke-free, and patients are provided support to help with their quit smoking while they're in hospital. This can also include referral to a pharmacist-led service on discharge, where the hospital provides ongoing support to smoking cessation. They have a really, really high success rate of helping people quit smoking and stay quit. And that, I think the numbers that I saw, as we can see on this graphic, is that once people go into this clinic, the cessation rate's about 42%. And relative to other health interventions for smoking cessation, that is a really high rate of quitting smoking. I touched earlier that we've had some changes in Australia. As we speak in this presentation tonight, the Australian Parliament is currently debating some changes to how nicotine-containing vapes or any vapes are to be supplied in Australia. And one of the potential changes that has emerged in the last couple of days is that the nicotine-containing vapes will transition from being a prescription-only product to a pharmacist-only medicine, effectively becoming a pharmacist-prescribed medicine. This bill, as I said, is before the Australian Parliament tonight and will be debated through the rest of the week. The government is seeking to support for the passage of this legislation because it is to accompany other regulation which would outlaw all non-therapeutic vapes from being sold outside of pharmacy and make enforcement much easier. Effectively, what the government's trying to do is to remove access of vapes to people who are under the age of 18 years, but to maintain access to vapes to people who are trying to quit smoking through a pharmacy and healthcare environment. One of the challenges with this is that there are no vapes currently for sale, registered with our medicine regulator, the TGA, and that does make it difficult to establish a therapeutic model here in the country. On that, I'm really looking forward to hearing the other speakers, and I'm happy to answer any questions people have about smoking in Australia.
Thank you very, very much, Peter. I really appreciate the time you've put into preparing your presentation. It's a great introduction and very broad range of activities that you've presented there. Let's now move north from Australia up to Taiwan. Our next speaker is Andre P. Wen Yu from China, Taiwan. Andre Pei Wen is a pharmacist. She's the initiator of the Taiwan Society of Community Pharmacy. Her career started in clinical pharmacy and then moved to adult education. And her personal motto is that education leads to better medication literacy and a healthier life. She's a certified tobacco cessation pharmacist, and I'd like at this time to invite her to give her presentation on the role of the pharmacist in tobacco cessation in Taiwan. Thank you.
Thank you, John, for the introduction. Hello, everyone. I'm Andre Pei Wen, and I'm delighted to be here today to share the experience about tobacco cessation services provided by Taiwanese pharmacists. Strictly speaking, Taiwanese pharmacists has been involved in the formal tobacco cessation service program for 12 years. It's a long story, but let me talk in brief. As early as 1997, the Tobacco Hazard Prevention Act was passed, which regulates non-smoking areas and age limits. Later, in 2002, Tobacco and Alcohol Tax Act created the Health and Welfare Surcharge, and the tax has been funding for smoking cessation services provided in hospitals and clinics. In 2005, Taiwan Anti-Tobacco Alliance was following the WHO Framework Convention on Tobacco Control, the FCTC. And the Alliance promotes FCTC signed in Taiwan. As the time went by, 2012 is a pivotal year for Taiwanese pharmacists providing tobacco cessation services. The second generation smoking cessation service listed community pharmacies as HPA contracted facilities. HPA is abbreviated from Health Promotion Administration. According to the latest statistical data, there were 814 community pharmacies and 1,419 pharmacists serving for the SCS program. The 6 months quit rate was 35.8% in the community. The second highest after the medical center in Taiwan. Taiwanese pharmacists have really done a great job. Next. Yes, thank you. In a broader sense, tobacco cessation services provided by Taiwanese pharmacists include 4 dimensions: dispensing, maybe for the prescription, for example, varenicline and bupropion, and even NRT. And SCS education, traditional OTC selling for NRT, and tobacco-free education to the public. First 2 services are limited to the HPA contracted pharmacies. A prerequisite for contracting with HPA is that a community pharmacy needs to have at least 1 certified smoking cessation pharmacist in practice. And how can a pharmacist become certified? Next. The HPA regulates the certification criteria and has set up the smoking cessation service training system for healthcare professionals. In addition to the training website, there is also a smoking cessation treatment and management website, where you can access the latest regulations, newsletters, and statistic data about SCS. And the next. Once a community pharmacist has completed the contract, they can provide SCS with reimbursement. SCS consists of 2 aspects: medication treatment and health education. Certified smoking cessation pharmacists can independently provide NRT, nicotine replacement therapy, for therapy, for the treatment without a prescription. In the case management model, the inclusion criteria for SCS medical treatment are an FTND score more than 4, or CPD, cigarettes per day, more than 10. SCS is free of charge for smokers on the National Health Insurance. As the picture in the slide shows, every smoker is required to take the fragrance stone test for nicotine dependence. In addition, the pharmacist evaluates smoking history, lifestyle, motivation to quit, and previous experience of quitting, and then provide individualized health education and treatment. Some smokers gave me their residual cigarettes to show their commitment to quitting, just like the picture. And the next. Here are the procedures for community pharmacists in the SCS program. According to the case management model, we completed the medical records and consultations, provide naughty medications and educations, key reimbursement system, and made an appointment. The visit fee includes 3 parts: medication fee, dispensing fee, and education fee. Medication fee and dispensing fee may be range from hundreds and to thousands, but unique. The education fee is more unique for the pharmacist. Is cost $100 per visit. After the treatment course, we need check-in on them at 3rd, 6th, 12th months, check if they quit or not, and the follow-up telephone calls valued at $50 each time. Next. As we know, tobacco use is one of the major risk factors for NCD, non-communicable diseases, also known as chronic diseases. Taiwanese pharmacists not only participate in the SCS program, but also play a role in health promotion activities, whether in communities or schools. One slogan is, "Beyond medications, healthier communities." We continue to encourage more and more pharmacists to become SCS certified because the pharmacist is the most accessible health professional in the community. Empowering pharmacists to support tobacco cessation? Yes, we can. That brings me to the end of my presentation. Thank you.
Well, thank you very much, Andre Peiwan. Really wonderful to hear the work that you're doing in China, Taiwan. Congratulations for achieving payment for providing some of these services. It's wonderful to hear, and I like the approach that you've presented. It'll be interesting to hear what questions arise. We will now move to our next speaker, and that will be Mohammed Hanaki Nik Mohammed. Hanaki graduated with a Bachelor in Pharmacy from the University of Science of Malaysia on Penang Island and has a PharmD from the University of Tennessee in the United States. He returned to his alma mater in Penang before joining the International Islamic University of Malaysia. He later obtained a certificate in global tobacco control from Johns Hopkins School of Public Health in 2011. Hanaki is the current leader of the Smoke-Free Campus flagship at the International Islamic University of Malaysia. He is the coordinator of Certified Smoking Cessation Service Provider Program, and he's been funded by the Malaysian Ministry of Health for a project entitled National E-Cigarette Survey. He has supervised more than 10 postgraduate students and authored or co-authored over 100 research articles, reviews, and book chapters, and notably co-authored a book entitled Secrets to Quit Smoking. Haneke is very experienced in this area, and Haneke, I welcome your presentation.
Thank you so much, John, for the kind introduction, and FIP for inviting me today. So good day to everyone. It's my pleasure to share with you some of the cessation services by pharmacists in Malaysia. So just a bit of background, almost 20,000 actively practicing pharmacists in Malaysia, particularly in the community and also the hospital. So from this number of pharmacists, we target them to be certified as smoking cessation service providers, so that they will be providing the smoking cessation and tobacco cessation, nicotine cessation effectively to all their customers and patients. Next. So we also have quite a high prevalence of smokers in Malaysia. It has been more than 20% over several years, from 2011 to 2023. We started to see a slight decline. The latest prevalence is at 19%, but still in terms of numbers, there are still more than 4 million smokers 15 years and above in Malaysia. So the question now is whether we are on track of achieving less than 15% by next year. So I'm not that optimistic that we'll reach this target, but anyway, we hope that we'll reduce the prevalence of smoking even more in years to come. Next one. So part of the National Strategic Plan for the control of tobacco and smoking products from 2021 to 2030 by the Ministry of Health is the integrated treatment at public hospital by increasing the number of smokers with chronic diseases receiving integrated treatment to quit smoking, particularly in the public setting. So they have targeted at least 60% of smokers to be registered and receive integrated treatment of quit smoking with the intervention of pharmacological and also behavioral. And 65% of the smokers, particularly those with high nicotine dependency, will receive pharmacotherapy when we look at the data over 10 years with a quit rate of at least 35%, which is high if you look at the data. But they set a high target so that more efforts will be put into it in order to achieve it. Okay, next one. So we have reported previously through other bodies, or including the Commonwealth Pharmacists Association, on the training community pharmacists in Malaysia as smoking cessation service providers. Also, as mentioned by panel members from other countries, particularly Taiwan just now, that we need to train the community pharmacists, hospital pharmacists, and those who are providing services to the public in particular, to have the right knowledge and skills so that they can help users quit effectively. So when we look at the next slide, please. Okay, we also have this program. If Taiwan is SCS, we call it in Malaysia CSCSP, which stands for Certified Smoking Cessation Service Provider. We launched it in 2004, and it's a collaborative effort from the onset, as I mentioned just now, to enable all our healthcare professionals actually, but as a pharmacist, we want to first equip the community pharmacists to acquire additional knowledge and skills to help smokers quit using evidence-based behavioral and pharmacological interventions. So what standards we use as benchmarks? We use the Association for the Treatment of Tobacco Use and Dependence, or ATUD, and our program involves, at the time, a self-study manual, and they later would come for a one-day workshop when we go through the content of the manual. And this is followed by a one-day or around 8 hours of attachment at any of the Ministry of Health quit smoking clinics. Later, as we want to increase access to the training, we started to develop an online module for the pharmacists and other healthcare professionals to do a self-study of the level 1. We call it level 1 using the module content. Next slide, please. So the level 1 will cover the basic topics on epidemiology, impact of tobacco use, tobacco control strategy in Malaysia, the understanding of nicotine and tobacco use dependence, and also the assessment. You heard before the use of Fagerstrom test for nicotine dependence. So that is also included. And of course, the crux of the training module is on the management of training of tobacco smoking and dependence using the behavior and pharmacological. And last but not least, how they establish and maintain a smoking cessation service. Okay, next slide, please. This is followed since we no longer require them to go for a one-day attachment at any of the quit smoking clinic facilities. We then offer a quick method to assess their skills through quick updates, workshops called Level 2 CSCSP, by having updates on nicotine dependence, assessment, and management. It can be 1 day or 2 days, depending on the preference of the participants. Okay, next one. So the latest one that we had was recently earlier this month, and as you can see, it's a collaborative effort among Ministry of Health, NGOs like the Malaysian Pharmacists Society, National Academy of Pharmacy, Young Pharmacists Chapter, and other bodies as well. Okay, next one. So this is usually at the end of the day or in between, we take pictures. So they're showing, this picture is showing the participants and as me as one of the lecturers and trainers and assessors. Okay, next one. Okay, so we want to know basically from all this training that we have done, what has been the impact on the practice. So we started off after a few years, we want to see whether there's any impact or effect of pharmacist counseling on awareness and willingness to quit smoking in the Malaysian population. So we found, yes, even in the prelim study, we found 67% of the participants showed willingness to quit smoking. So meaning that pharmacists offering smoking cessation counseling seems to be helpful in motivating smoking cessation. Next one. Later, we also have studies from colleagues in various facilities, and this one is my colleague from the first university where we established the first multidisciplinary dedicated quit smoking clinic. So this university-based smoking cessation program involved not just pharmacists. I was the pharmacist there to initiate, but there were also physicians and also nurses. So my colleague, Prof. Muhammad Izham, then evaluated this clinic and found that a quit rate of 23.26% with 30 quitters out of 129 clients who participated. Okay. We don't reach that high of 35% as the quit rate by the Ministry of Health, but we know that anything above 20% is actually a very good quit rate already. Next one. So there were also studies by other colleagues, pharmacists in Malaysia, looking at treatment outcome assessment of pharmacist managed quit clinic in Malaysia. This particular study actually found a low quit rate, which was 5.8% only, with a high default rate. So this was a tertiary hospital in one of the states in Malaysia. So it despite of the low rate, the pharmacy delivery of smoking cessation services at the public funded quit smoking clinic associated with high default rate, the author actually still want to look at the issues and challenges, for example, leading to the high default rate. Okay, one of the reasons cited usually would be the lack of medications provided in the service. Next one. So another study reported quit rates at 6 months with a higher quit rate than previous studies. This time around, they reported 42.6% success rate. So we then begin to identify that when you give free pharmacotherapy and counseling, and then with proper follow-up, it seems to have an impact on the cessation rate. And you can also have tools, for example, the carbon monoxide breath analyzer, to motivate the patients to come back and also report validated or verified cessation rate. Next one. Okay, so we also understand, as in other countries, we need to further explore the professional pharmacy services offered by, in this case, community pharmacies in one of the states in Malaysia. So one of the challenges cited was lack of commitment among the smokers, and they also reported that the smoking cessation interventions by community pharmacists in particular has a higher success rate when both counseling and medications are offered. So lack of availability of medication seems to be cited as a problem, a barrier, since it can lead to lost opportunity in helping smokers to quit and reducing the motivation of pharmacists to provide the service. Next one. Another study, this one by colleagues also, pharmacists, look at more than 400 community pharmacies, and more than 50% were already certified. Good to note that more than 50% provided counseling or smoking cessation, although I wish 100% would be providing counseling. But anyway, 53% reported having pharmaceutical care services to patients with chronic diseases, and cited some barriers, including high price of the medicine, close proximity of community pharmacies with each other, and lack of public awareness. Okay, next one. So these are some of the pharmaceutical care services provided by the pharmacists in the study, and it's good to see that smoking cessation is more than 50%, as well as other type of services by the pharmacists. Next one. So we also have a book chapter on the smoking cessation counseling perception and barriers among community pharmacists. So in this particular report, majority, almost all of them were already certified smoking cessation service providers, and 65% of them emphasize the needs of patient counseling or smoking cessation. But then this is one of the instances when we found that the barriers faced by community pharmacists were lack of knowledge and training, despite a high percentage of people being certified. Okay, and there's also issues on reluctance of behavior change among the patients, and of course, lack of time for counseling for all the patients. Next one. So what we can summarize from the evidence and the experience that we had, we know that continuous education and training will still be needed for pharmacists, as the complexities of smoking cessation is now confounded with vaping, and we want to also provide vaping cessation services, especially in dual users. And we also found that altruistic, financial, and practical considerations are actually the drivers for the provision of cessation services. And barriers, whether it's intra or extra organizational, will impede service provision and expansion. Therefore, this need to be addressed adequately. For example, facilitating seamless transition from care beginning from the hospital or community setting, or vice versa. For example, using telehealth or telemedicine. And we know that interprofessional opportunities for cooperation and also provision of strategic incentives can drive this national agenda forward. Okay, so I think that's all from me. Love to hear your feedback. Thank you so much.
Haneke, thank you very much. Great presentation. Wonderful, all the work that you're doing in this space. And I'm sure there will be some questions for you following the final presentations. So, look, it gives me great pleasure to move on to our next speaker. We're now going to hear about the role of the pharmacist in smoking cessation in Japan. And this presentation will be by Mr. Atsushi Toyomi. Atsushi is a graduate of Hiroshima University. He qualified as a pharmacist in 1997 and worked in hospital pharmacy before moving into community pharmacy. But since 2018, Atsushi has been the executive director of the Japan Pharmaceutical Association. It gives me great pleasure to invite Atsushi to give his presentation. Thank you.
Thank you, John, for the great introduction. And thank you all for coming. I'm honored to have this opportunity. My name is Atsushi Toyomi, Executive Director of the Japan Pharmaceutical Association. I work as a pharmacist at a pharmacy in Hiroshima. Today, I would like to talk about the smoking situation in Japan and the role of pharmacists regarding smoking. First, let me talk about the situation in Japan. Due to greater health consciousness and various policy measures, smoking rates have declined. According to the most recent survey, the smoking rate is 25.4% among men and 7.7% among women. Smoking rates have declined sharply among younger people, especially those in their 20s. However, the decline has slowed down in recent years. Some say this is due to a shift to heated tobacco, electronic cigarette products. The graph on the right shows the types of tobacco smoked by men and women in different age groups according to a recent survey. We can see a shift from cigarettes to heated tobacco products. I will now talk about measures that, I will now talk about measures the Japanese government has taken regarding tobacco since 2000. Health Japan 21 is a policy designed to promote public health in the 21st century. The first phase of this policy, which began in 2000, focused on providing information about the risks of tobacco and on building health-promoting environments. After that, in 2010, tobacco taxes were raised, which encouraged a decline in smoking rates. As you can see, the third phase of Health Japan 21, which will start in 2024, sets numerical targets to achieve by 2032. Japan is also working to implement the WHO's Empower measures. Our evaluation of these measures is shown on the lower right. The current evaluation points out that smoking rooms are available, that there is no free smoking cessation hotline, and that warnings on packaging are provided only in written text. This is not a very good evaluation. Japan is an aging society. The role of pharmacies, which have focused too much on the dispensing of insurance-covered prescriptions, needs to be reformed. Approaching people before they become sick is extremely important, so a health support pharmacy system is being developed with this goal in mind. The purpose of this system is to make it easier to identify pharmacies that support local residents in maintaining health and increasing healthy life expectancy. It allows pharmacies that meet certain requirements to call themselves health support pharmacies after notifying their prefectural governor. In addition to attending training sessions and organizing regular health classes, pharmacists are required to provide smoking cessation aids, with the aim of supporting the health of local residents by helping them quit smoking. The JPA is committed to providing this training and is working to develop pharmacies that support the health of local community residents. Here is a list of smoking cessation medication used in Japan. Nicotine gum and nicotine patches are available over the counter. 30 square centimeters nicotine patches are not available over the counter. Examination at medical facilities are required to use them. Since 2006, smoking cessation treatment using nicotine patches has been covered by health insurance when patients who meet certain requirements receive their prescriptions from medical institutions that also meet certain requirements. Distribution of varenicline is currently halted in Japan, but it received coverage starting 2008. Smoking cessation apps and CO checkers have been covered by insurance since December 2020. Varenicline and nicotine patches are available by prescription and are dispensed at the pharmacies. If your copayment rate is 30%, your cost will be around 6,000 yen at the clinic or hospital, and about 7,000 yen including medication at a pharmacy. Some local governments and insurers subsidize the copayment portion. Over-the-counter medications designed to help people quit smoking are sold at health support pharmacies. New insurance rules established this June also require these pharmacies to handle these medications. The rules for dispensing fees that came into effect this June also set a direction for smoking cessation. If they meet certain requirements, pharmacies can claim the so-called premium for community support systems when dispensing all prescription drugs, not just smoking cessation medications. Pharmacies have various functions expected by local communities, such as stocking at least 1,200 medicines, providing services at night and on holidays, and implementing measures to help ensure medical safety. These include the installation of consultation booths designed to protect privacy, which are useful for helping people quit smoking, and the sale of over-the-counter medicines include smoking cessation aids. In addition, pharmacies are prohibited from selling tobacco products. Most pharmacies are expected to aim to meet these requirements, which stipulate what a pharmacy should be, and are working to become places that support smoking cessation. One issue that needs to be addressed is public awareness. The establishment of this system and the Health Support Pharmacy initiative needs to be made known to local residents. Japan has what is known as a school pharmacist system. All schools are required to contract with a school pharmacist as with a school doctor and dentist. Under the school pharmacist system, local pharmacists provide guidance and advice on environmental hygiene and safety management. School pharmacists inspect environmental hygiene at schools in addition to checking classroom ventilation and lighting. They test the quality of tap water and swimming pools. Since all of these are subject to national standards, they check to see if these are met and report the school principal. The main role of school pharmacists is to provide guidance and advice to help students enjoy a comfortable school life. Other important duties of school pharmacists include providing drug abuse prevention classes, raising awareness about drinking and smoking, and educating students about the correct use of medicines. Curriculum guidelines stipulate that students should learn about the harmful effects of smoking. School teachers sometimes conduct these classes, but school pharmacists often conduct them as well from their professional perspective. The photo on the right shows me giving a lesson to 10-year-old children. The children write reports, and many of them write that they now understand the harmful effects of tobacco. Every year, to mark World No Tobacco Day, pharmacies put up posters encouraging people to quit smoking. This year, Hideki Kuriyama, who led Japan's team at the World Baseball Classic, has been featured on the poster. He also mentored Shohei Ohtani and is popular among middle-aged and older men. I would like to introduce an initiative in Japan that was highlighted in the latest FIP report. It's about the effect of smoking cessation support programs at community pharmacies. A study found that telephone support from pharmacists had a small but significant effect on maintaining smoking cessation. I believe that providing services like this, which supports the health of local residents and have nothing to do with prescriptions, is something important pharmacies can do for their local communities. Thank you for your attention. Thank you.
Atsushi, thank you very, very much. It's wonderful to hear the work that's happening in Japan. And again, there were a number of very interesting things there that you referred to that I'm sure will come up in our question and answer session shortly. Following those 4 presentations from different countries in the region, I now want to hear from FIP itself. And our speaker will be Ines Nunes Dacuna. Ines is the FIP Practice Development and Transformation Projects Manager, leading the FIP Practice Transformation Program on non-communicable diseases. She's the lead and co-author of the FIP publications Tobacco Cessation, a Handbook for Pharmacists, which came out last year, and Pharmacist-Led Tobacco Cessation Services Global Intelligence Report, which came out this year. Ines, please speak to us about the work that FIP is doing and the support it has available. Thank you.
Thank you very much, John, and thank you to all the colleagues who presented great examples of pharmacist-led tobacco cessation services in their countries. I really think it is inspiring to hear these different examples and to learn with colleagues from different countries. And today, it is a great pleasure for me to share with you the work that FIP has been doing in the field of tobacco cessation and what pharmacists can do to help individuals to stop using tobacco. FIP has been working for several years in the field of non-communicable diseases, NCDs, and in particular, tobacco cessation as part of our commitments to the WHO Standard Declaration on Primary Healthcare signed in 2018. One of the ways FIP has been doing this is through the FIP Practice Transformation Program on non-communicable diseases that you can check more information in our NCDs microsite. I will also share all the links I will present to you. I will have them on the chat after my presentation. So this program aims to provide tools and strategic support to FIP member organizations to develop and implement pharmacy services that can have a sustained positive impact in the prevention, screening, management, and treatment optimization of non-communicable diseases for improved patient outcomes and health systems efficiency and sustainability. The program initial focus on 5 disease areas that you can see on the slide: cancer, cardiovascular diseases, chronic respiratory diseases, diabetes, and mental health, but also on risk factors for these non-communicable diseases, such as tobacco use. Because tobacco use is a risk factor that can affect and trigger all of these diseases, but in particular, chronic respiratory diseases, cancer, and cardiovascular diseases. So in addition to developing resources such as handbooks and knowledge and skills guides for pharmacists in each of these 5 disease areas, which are available on the FIP website. As I said before, we also developed specific resources focusing on pharmacist-led tobacco cessation services. This includes the handbook you can see on the left of the screen, and for pharmacists supporting tobacco cessation and tobacco dependence treatment, which was launched last year on World No Tobacco Day. And also the FIP Knowledge and Skills Guide, which describes the knowledge and skills pharmacists need to provide effective tobacco cessation services. These publications are also available on our NCD's microsite. These resources are also available in Chinese, French, Spanish, and Turkish, and we will soon have translations of these resources available in Arabic. Also in 2023, FIP launched a holding statement on the use of electronic cigarettes. As been mentioned before, electronic cigarettes are becoming more and more popular, especially among younger adults and teenagers, due to flavors and strategies that make them very appealing, and also to a certain misperception of these products as being harmless to health, which is really not the case. And so FIP has therefore published this holding statement to inform about FIP positions on the use of these products. FIP also started to work at country level to support our member organizations, particularly in Jordan and India. We have started to support these two countries because they have a higher prevalence of tobacco use. And Jordan, in particular, is one of the 6 countries in the world where prevalence of tobacco use was actually increased. And we have started with these 2 countries, but we will probably support our member organizations in other countries as well. On World No Tobacco Day this year, FIP and the WHO issue a joint statement on the role of pharmacists in tobacco cessation. This statement describes a number of ways in which tobacco control programs and pharmacy associations can work together through the aim of develop and implement plans to engage more pharmacists in advancing tobacco cessation. This joint statement was presented during our webinar, leveraging pharmacists for tobacco cessation, new policies, tools, evidence, and success stories. And during the event, Dr. Vinaya Prasad, head of the WHO No Tobacco Unit, said that this statement calls for a collaborative effort among healthcare professionals. Specifically, it advocates national action to empower all pharmacists to routinely provide tobacco cessation support. And Dr. Prasad added that if every pharmacist identifies and advises just one tobacco user to quit each day, this collective action could reach over 4 million users in a single day. So we have a huge role to do in this area. At this webinar, FIP also launched the Global Intelligence Report on Pharmacist-led Tobacco Cessation Services. The full version of this report is only available to FIP members, but the Pharmacist-led Tobacco Cessation Services Evidence of Impact and Country Highlights version is available on open access. You can also have access, open access to the FIP Global Tobacco Cessation Survey findings infographic. So the basis for this report was established through a review of existing literature, in addition a survey and a compilation of country highlights specifically tailored to engage FIP member organizations were conducted. And today we had here with us 4 countries that provided us insights, and we have incorporated them in our reports. And this report provides a comprehensive overview of the key role of pharmacists in tobacco cessation and how this contributes to timely patient care and to health systems efficiency through interprofessional care teams. The report also shares the global best practice to advance pharmacy practice and international standards of patient care. Throughout June and July, we'll be running a series of digital events focused on empowering pharmacists to support tobacco cessation. And today, this is the first of 6 events. And we are also be working on a FIP statement of policy on the role of the pharmacist in establishing a future free from tobacco and nicotine dependence to be adopted by the FIP Council in Cape Town in September this year. So in summary or in conclusion, the negative effects of tobacco use on health are well documented. However, giving up tobacco and quitting can be a challenging process, but the journey towards a tobacco-free life can be made easier with the right support. And pharmacists have an important role to play in helping tobacco users quit and remain abstinent. Pharmacists' expertise and accessibility ensure they are ideal providers of evidence-based advice, medication, and support to those who want to break their addiction to and dependence on tobacco. So all the program publications, events, recordings, and other resources and tools are available on the FIP microsite on NCDs, ncd.fip.org. You can also have all the information, and if you have any queries, suggestions, comments, everything is welcome, and you can send us an email to ncds@fip.org. And thank you so much. Back to you, John.
Yes, thank you very, very much for your presentation. Thank you for all of the work you're doing in FIP on this important topic, and thank you for organising this evening's webinar, the first and the best of the regional webinars, I'm sure. Okay, so we have some time available to us, and so we're now going to have some questions for our speakers. There are a number of questions that have been put into the Q&A, some of which have already been answered. And what I'd like to do is start with a question that's come in from Suresh Chudhari. And I'm going to ask Peter to answer this one, and I might move on to one of the others in a second. But this question, Peter, is how can we prevent relapse after helping somebody successfully quit tobacco? So what are your thoughts, Peter, about preventing relapse?
Thanks, John. It's a really good question. We know that I think in Australia, the data says that the average person will have I think at least 7 or 8 quit attempts before they quit tobacco permanently. And that relapse or people taking up smoking again, it can occur at different stages of life, whether that's in response to a stressor or whether there are environmental factors that contribute to that. So I think one of the key factors about avoiding people returning to tobacco smoking is the quality of the intervention in the first place. We know, and John presented data earlier, that the more involved a health professional is at the quit attempt, the more that sets somebody up for long-term success in the future. And the models that we look at need to reflect that. The medicines help people at the time with a physical dependence, but the other aspects of nicotine dependence are psychosocial, and there's a huge role for health professionals there to play in helping people be able to manage those in the future. And it may be referring on to other health professionals other than pharmacists as well, like psychologists and quit smoking counsellors as well.
Thank you, Peter. I'm going to follow up from Peter's answer and ask Hanneke to address the question of telepharmacy, because he made reference to it during his presentation. I would have thought one of the ways to help somebody to stay smoking free, tobacco free, would have been repeated contact, which obviously could be done through a telepharmacy consult. So Hanneke, could you talk to us about the value and the success of telepharmacy, both in the initial phase of getting somebody to stop, but more importantly, in keeping them smoke-free?
Thank you, John. Very relevant question. Yes, we have data coming out recently about the positive impact of using telehealth, telemedicine, and AI, chatbots, many digital tools to assist healthcare providers and also the clients or the patients themselves to get the up-to-date information and also to fulfill the needs for the follow-up sessions. As you know, under the 5A strategies, we have from asking, advising, assessing, assisting, and the last A is on arranging or follow-ups. So as the session can be anywhere from 8 to 12 sessions per patient, and then we can have it on an individual basis or group basis. So the telehealth, telemedicine has been very useful in addressing this issue, whereby customers, clients, patients, whatever you call them, do not need to go physically to any of the pharmacy or the clinics, but they are reachable, they're contactable, and the health professionals are accessible on the time agreed upon mutually for the sessions to progress. With digitalization, and as I mentioned, WHO has even launched its own AI tools or digital tools for smoking cessation. I was one of those people who tested it. I registered as a smoker, so I wanted to see what is the response. How do they send their messages? So I found it very interesting and actually very useful because they send reminders. They send behavior messages. They also ask about my level of withdrawals and so on and so forth. So all these tools are at our fingertips to be shared with our patients so that they will get the assistance as they need it without us being there. But we can then also schedule our follow-up. So it's complementary to a certain extent, but it's very beneficial, especially for the younger generation who are very savvy about digital tools. So that's my quick response, John. Thank you.
Excellent, thank you. Look, it leads me on to a question for Andre P. Wen, who made a very good point about the fact that you can use both behavioral and pharmacological approaches to smoking cessation. I mean, we are pharmacists and perhaps we see everything through the lens of the medicine. But Andre P. Wen, can you talk to us about how you blend together the behavior change with the pharmacological?
Yes. For if we met, if any smokers who search for our professional advice, for example, I think that a community pharmacist is the most accessible for them, and the trust is in the community health professional. So every time we talk about their treatment course, but not only for treatment course, we will talk about their habits and their daily life. Yes, we will discuss on what time you want to smoke and why you want to smoke. So maybe sometimes it's caused some smokers that it caused by their pressures, and maybe some is caused by their habits, or even some is for they don't have they have nothing to do, so they want to smoke. So we need to clarify the timing they want to smoke, and we will discuss how can we use the medications to replace the tobacco use, and for many for different kind of patients, they will have their own reasons for use the medication. For example, that the NRT, it have a lot of different kinds of dosage. Maybe someone is more appropriate to use the page, and someone use the gum, and someone for lozenges, and even for inhalers, or maybe for the spray. According to their different kind of health, life, and habits, I think that it needs more detailed discussion with our cases.
Thank you. Thank you very much. I'm very, very interested in that pharmacists believe we have a role to counsel patients and believe we're very good at this. But counseling somebody about their regular medicines, I think, might be different to trying to change somebody's behavior around an addiction. So what is the training that smoking cessation pharmacists in Taiwan receive to help them be able to counsel patients about behavior change?
Yes, and maybe for behavior change, we will choose some different kind of lifestyle change for maybe do more exercise. We will discuss what kind of exercise can relieve the pressure for the patients, and maybe bicycling, or maybe jogging, or maybe another one. But I think that exercise is very good when they are under quitting procedures. Yes, and the others is that we will search for their family support. Yes, the family support is very important for them, because when the smokers is under quitting treatment or creating health education, they will feel more pressures. It will face a lot of symptoms that for the creatines. So I think that the family support is very important for them. So sometimes we will talk about their family. If they can't, they can bring their family together, and we will discuss together.
Fantastic. Thank you for that. I've got one final question, and there's just a couple of minutes, and this is to Atsushi. Atsushi, you mentioned the app, app that pharmacists can help people use. I think it was called CO Checker. And I think Haneke also mentioned a device. But Atsushi, can you explain for some of our people who might not be familiar with the CO Checker how this is used in trying to help somebody in smoking cessation?
Once more, please.
Yes, Atsushi, I was just wondering if you could please briefly explain how the app, the CO Checker app, is used to help people.
Okay. Sorry, I don't know where that CO Checker and app is direct doctor to patient direct. There,
Right. Okay.
We can't.
Perhaps then I'll ask Haneke, you did mention devices that could be used. So very quickly in the couple of seconds we've got left, Haneke, would you like to tell us what you think can be used in that space?
Yes, thank you. Carbon monoxide has been used as a biochemical verification of smoking, especially combustible tobacco products, and also of abstinence. So it can be linked to apps, it can be linked to smartphone applications, and then you can have real-time data of the patient's CO level. for monitoring, motivating, and also helping them to understand they are improving their health, particularly their lung function. So these devices are useful, particularly for these purposes. Thank you.
Thank you, Haneke. So we have a spectrum there of pharmacotherapies, some devices, and also behavioural change. Now I actually have to come to the conclusion of this program. We do, of course, have to thank all of our speakers. I think they've done an excellent job. Thank you to everybody. But just before we wrap up, there's just a couple of slides that will show you the coming events. There's, of course, the FIP Congress, which will be held in Cape Town later this year. So thank you for attending. We appreciate you spending this time with us, and we hope you found this to be a useful program. Thank you and good evening.